Welcome. It's wonderful to have this turnout. Obviously, you're all aware of how important this issue is. Um, I am going to be introducing Bobby Cole, but I also want to introduce the nurses here. We have a program here of a number of different nurses who provide and really support health care here at St. Peter's and in the community. And I'm so glad that all of you have taken the opportunity to come out and learn something about stroke. May I introduce Bobby Cole, who is the stroke coordinator at BB Hospital. She will be presenting the program. Bobby.
Thank you. Good afternoon, everybody. Thank you for coming. Community education is the #1 step to prevention, correct? So, who is familiar with stroke? Has anybody had a stroke? Has anyone had a family member with stroke? Okay. Stroke is the leading cause of disability, permanent disability, in the United States. A more striking factor is stroke in Delaware. We are the 3rd highest mortality rate in the country. That is not wonderful. That is awful news. So that's why I come out to communities and I try to educate about not only the risk factors, but we talk about your modifiable, non-modifiable risk factors. We talk about the signs and symptoms. The best thing that you can do with stroke, and we'll talk about it, is recognizing those symptoms early to get early treatment. We're going to talk about the time. So for those who have family members that have a stroke, do you know if they were ischemic strokes caused by a blood clot? Do you know if they were hemorrhagic strokes, which is a brain bleed? Okay. Hemorrhagic strokes are extremely more fatal than ischemic strokes. Okay, but time is important in everything. So let's start off with risk factors. Okay, so we've put them into 2 different buckets, and I really like to get your input. I really like to interact with the crowd, so don't hesitate to speak up, okay? You don't have to put your hand up. If I hear multiple, I might just ask you to repeat yourself, because you intertwining with me and collaborating with me will help you retain the information. Mary Beth had mentioned to you guys it's important to eat while you learn. It actually helps. It's true. I don't just say that. There's actually scientific evidence behind it. It helps keeps your sugar up. Obviously, don't sit here for 3 hours and eat Snickers bars, but it helps keep your sugar up and it helps keep your focus. Okay, so you kind of tend to retain a little bit more of the information. So let's talk about statistics. How many strokes do you think occur in the United States every year? 795,000 estimated. How many of those do you think are first-time strokes? About 610,000 first-time strokes. If you have to guess a percentage of strokes that are preventable, what percentage of strokes do you think are preventable? 80% of strokes are preventable. That's why I'm here today, okay? I educate everyone from middle schoolers to high schoolers to senior centers, everybody across the age spectrum, because nobody is 100% exempt from having a stroke, okay? So let's talk about some risk factors. I like to talk about risk factors, then I talk about signs and symptoms, and then I go into the different types of stroke, and then we'll talk about questions and answers after that. However, if we are talking about something and you do have a question, feel free to ask the question, okay? Because I don't want you to forget your question. So for risk factors, we put everything in 2 buckets, modifiable and non-modifiable. What is a non-modifiable risk factor? Age, right? At what age do you think you're at higher risk for stroke, just based on age? 55. Okay? 55 and above, you're at greater risk for stroke. Here's the scary factor. Every decade after that, your risk factor doubles. Every 10 years, just based on age, your risk factor doubles. That's why as you age, it's more important for us to control our controllable risk factors. Okay? What else is a non-modifiable risk factor? Things we cannot control.
Family history.
Family history. I'll get to that. Who do you think's at higher risk for having a stroke as far as race goes?
Everybody's been white.
African American and Hispanics. Why? Diet, lifestyle, but bigger facts, racial disparities and lack of health care. So I really try to go to some of these other communities and educate them on the signs and symptoms and the fact that they need to get help. Okay? We have to stop the racial disparities. A lot of them, when I talk to them, are like, well, if I go to the doctor, they always just tell me nothing's wrong. So we try to change the stigmas through education. Okay? We got to start that at a younger age. Socioeconomic status is huge in both of those races. Okay? So we monitor that as well. What else is a non-modifiable? So we have age, race, family history, which I'll fight to some extent. I'll get to that though, so hold that. What else? Gender. Who do you think's at higher risk of having a stroke?
Men.
Who says men? Who says women? Men, statistically, are at higher risk for having a stroke. Who do you think has more strokes? It's accurate. To the tune of 55,000 more a year. Estimated. Who do you think dies more from strokes?
Women.
All right, who says men? Who says women? Why do you think more women die from strokes than men?
Ignore the symptoms.
One cause.
They're different symptoms, and you might not recognize them.
Possibly. I hate to say it, men, but statistically we live longer than you. So therefore, we have strokes later in life. We have a difficult time with the complications. Men who have strokes typically have strokes at a younger age. They have a better chance at a positive outcome. I will tell you, we are also guilty for having something better to do. My arm is weak. I just slept on it wrong. I've been out gardening all day. I have a really a bad headache and I'm nauseous, but I was just out at the beach. Were you out at the beach or do you have a brain bleed? So we're going to teach you the different signs and symptoms and what you guys should be looking out for. So those are some of the non-modifiable risk factors. So then we move into modifiable, things you can control. And I have two buckets for that bucket. All right? I have lifestyle choices and I have medical conditions. Both are controllable. Let's start with lifestyle choices. What lifestyle choices do you think put people at higher risk for stroke? Obesity. Who's familiar with a BMI? Body mass index. Greater than 30, you're at a higher risk for stroke. Normal is less than 24.9, so I like to say you have a little bit of fluff room. Okay. What else about lifestyle choices? Yeah, sedentary lifestyle. We like you to exercise at least 30 minutes a day, 3 to 5 times a week. I do education at Truett Homestead. They're like, why walk with a walker? Okay, go out your room, walk to that elevator, go down the elevator, come back down the hallway, and go back up. It's going to take you a little bit. Do it 3 to 5 times a week. Okay? Just stay active. That's going to help. What else?
Diet.
What diet?
High salt.
High salt, high cholesterol, high fat. Okay? I'm not telling you to eat a cardboard box. Just telling you to be mindful of what you're putting in your body. Because I can't say I eat the healthiest. I am 100% guilty of that. What else? Lifestyle choices. Smoking. Drinking.
Drugs.
How much is too much?
More than, I read this. More than
You
4
cheated.
drinks.
Yes.
4 drinks a day?
So moderation, right, for women is considered 1 drink a day. Men is 2 drinks a day, right? But when you go into the high risk factor for stroke, we're looking at 4 drinks per day. Okay. Smoking includes vaping. Smoking includes vaping. A lot of people do not put vaping in with smoking. It is. It can cause vasoconstriction, which cuts off circulation and oxygen flow to your brain. What else? We got smoking, alcohol,
Drugs?
drugs. Which drugs?
Well, or
Your stimulants are the ones that will put you at the highest risk for stroke. So don't go do methamphetamine and don't do cocaine. You won't have a bleed.
Heroin's
You'd be
okay, right?
surprised. Heroin is not okay.
How about marijuana?
That does not make
marijuana.
Okay, that's a whole different topic. Okay.
Trauma.
That is not considered a spontaneous intracranial hemorrhage. That is a traumatic hemorrhage. So they are different. So when I talk about the different types of strokes, I absolutely will talk about the differences, because some people think if they bump their head, they had a stroke. No, they bumped their head, which caused trauma to their head, which caused the bleed. But we'll talk about that. So we got all our lifestyle choices. What about medical conditions do you think put people at risk for stroke?
High blood pressure.
How much is too much? Well, you cheated on the last thing. Greater than 140 over 90. Nowadays, greater than 130 over 80 is considered hypertension. If you have a non-traumatic intracranial hemorrhage, frequently your blood pressure is 200, greater than 200 over 100s. And I say uncontrolled hypertension is the #1 cause of an intracranial hemorrhage. I mean, you have a really bad headache. Okay? So we try to keep blood pressure under control. What else?
Cholesterol.
Does anyone know their cholesterol numbers? Not off the top of your head.
I was at the doctor yesterday.
Are you willing to share?
My cholesterol, my good cholesterol is low, and my my bad cholesterol is low, but my triglycerides are high.
Are high. Okay. So she's got sticky blood. Yeah. So for total cholesterol, we like to try to keep it less than 200. Has anyone heard of an HDL or an LDL? Which one's your good cholesterol? How many think your LDL is a good cholesterol? Oh,
H is
thank
helpful.
you. You guys understand cholesterol.
I
Yes.
heard something in nursing school, and I this is the easiest. I always think if H is heavenly
Yeah.
or high. I want to have them high.
And L is lousy.
And or lethal.
Yeah. So lousy density lipoprotein is your bad cholesterol, LDL. We want that less than 70. HDL, we really try to get greater than 45. Okay, that's your heavenly density. When it comes to the stroke program, we monitor LDL and total cholesterol. That's what we base our medication on. If your LDL is greater than 70 and you're under the age of 76, we're going to put you on a high intensity statin. That doesn't mean severe, it's just a level of statin medication, and it's usually 40 grams of Lipitor, 40 milligrams of Lipitor, or 20 milligrams of Crestor. If you're greater than 76 and your LDL is still elevated, we drop it down to a moderate intensity, because it's just how your body metabolizes it, okay? So what else besides, so we have high blood pressure, high cholesterol. What other medical conditions? Diabetes. Does anyone know what an A1C is?
I do. I know.
What is your A1C? She's an encyclopedia.
Are you a nurse here, Barbara?
No, I'm a doctor.
She's an encyclopedia. What is your A1C level?
My A1C 2 days ago was 6.7.
Perfect. Okay. That's a well-controlled A1C for a diabetic. They consider for first-time diabetics greater than 6.5 to be at higher risk for stroke. Does anyone know what is your A1C indicative of?
Your blood sugar over the last, I think it's 3 months.
3 months. It's basically an average blood glucose that you have maintained expressed as a percentage over the previous 3 months. It lets us know how well you're controlling your sugar. It doesn't lie. Okay. We really do check in on stroke patients, and it's because if we have a stroke with a prolonged last known well time, they may not have felt well the last couple days. So when they come in, their blood sugar might be low, But just because their blood sugar is low today doesn't mean their A1C wasn't the cause of their stroke, because their A1C may be up. So we always check an A1C on folks, regardless. We have a lot of patients come in with no history of diabetes whose A1C level is 13. They have diabetes now. They just never knew. Okay. What other medical conditions? AFib. What is AFib? I know that. What is going on in the heart? How does it cause a stroke?
Going too fast. The upper chambers.
Upper chambers. If your bottom chambers are going too fast, Houston, we have a problem. So you have 4 chambers in your heart, right? You have 2 uppers, 2 lowers. Atriums are up top, ventricles are down below. When your atrial fibrillation, they are doing this. They are literally fibrillating. AFib RVR, this is going more than 300 beats per minute. The bottom, your strong chambers, your ventricles, are pumping greater than 100 beats per minute. Why is this ineffective? What happens to blood when it doesn't move? Yeah, clots. Hello, ischemic stroke. So this can actually cause microclots, which are small enough to go through the lungs and then get back into the bloodstream, and it causes what's called a watershed infarction. If you look this up on your phone, it literally looks like someone's head is lit up like a starry sky. They have multiple tiny strokes, and it's these microclots. And whenever we see multiple lacunar infarcts, we're usually guessing that they either had AFib and they had to stop their medication for some type of procedure, or they had AFib and they're finding out about it right now. Okay? AFib is a huge deal. We don't automatically put everybody that has AFib on an anticoagulant. We will work with cardiology to do a risk score and make sure it's safe. The benefit is greater than the risk to put you on an anticoagulant. Okay? Sometimes it's just 81 milligrams of aspirin, which is just an antiplatelet. It's not even an anticoagulant. Okay? What other cardiac issue? We have hypertension and AFib. No, that's okay. Yeah. Atherosclerosis, CAD, coronary artery disease, anything that affects the vessels in the heart. Okay. What respiratory condition do you think puts someone at risk for a stroke? Nope. He knows. He's listened to it before. Does anyone have sleep apnea? Do you wear your CPAP?
I do.
Thank you. I have a number of stroke patients that come in and they have sleep apnea, and I said, do you wear your CPAP? I don't even know where it is. I can't put that thing on my face. How do you think it causes a stroke? Well, so with sleep apnea, they stop breathing. So when you stop breathing, your oxygen level tanks, and it's the repeated insults of low oxygen levels that can cause an ischemic stroke with sleep apnea. Okay, so please, 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 if the mask bothers you, see if you can switch to the nasal pillows. If that bothers you, check out Inspire. That's that new fancy thing that they actually implate, that they like push a button and it like breathes for you. It's weird. Any questions on the risk factors? So let's talk about family history. So when I have a patient that comes in, realistically, when I have a patient that comes in that says, well, my mom had a stroke, or stroke runs in my family. Why did they have a stroke? Were they smokers? I let them tell me their story, but I also let them know that in 80% of the cases, they can break the cycle. Okay? They don't have to eat preserved foods their whole life. They don't have to have, there is a genetic and hereditary component of cholesterol, but we can do everything we can to control it. Everything you do to drop your risk factor, I promise you, significantly drops your risk factor for stroke. Every little thing. Every kilogram, does anyone know how many pounds a kilogram is?
2.2.
Every kilogram you lose will drop your blood pressure 10 points. Every kilogram you lose can drop your blood pressure up to 10 points. It doesn't take much, okay? So just be mindful of your own risk factors, okay? Any questions about the risk factors before we move on to the signs and symptoms, because that's where things get fun? Yes?
How do people know they have sleep apnea unless they have that test done? I thought my husband did when I think back on it.
Mm-hmm. So we go through a series of tests. There's high risk for sleep apnea. And one of the questions is, have you ever been told that you stop breathing when you sleep? People don't realize they have sleep apnea sometimes until they get the test done and get fitted for a CPAP and have the best sleep of their life. Then they're like, oh, I really did have a problem. Okay. There's two different levels of sleep apnea. I think it's the condition and the syndrome. I'm not 100% sure. But one is you stop breathing 5 times a night. The other one is you stop breathing 5 times an hour. Yeah. I had a friend, they recorded him, he stopped breathing 162 times in one night. And I don't know how.
Feel like your sleep
Just
is
exhausted during the day.
exactly, your sleep is just not good.
Yep. Yep. Yes.
Well, the other thing is, if you wake up panicked in the middle of the night and you think you just have that dream, I didn't realize it was because I wasn't breathing.
Oh, really?
Yeah.
I didn't hear that. That's
Yeah,
interesting.
The doctor said, oh, I'll give you something to make you relax. Totally missed it. Because
So they were giving you something to help you sleep more?
no, they were giving me something thinking I'd be more relaxed.
Oh,
But they missed the fact that that was
that you had the sleep apnea. Interesting. That's why I like having these, because I learn little tidbits of people's stories, and it helps me share it with other people, because I guarantee you there's someone else, either in here or somewhere else, that has had that same thing happen. So that's good to know.
This might be off the wall, but I've had a couple of dreams over the last few months that in the dream I'm having a hard time breathing. I can't get a full breath.
When's the last time you saw like your primary care cardiologist?
Actually, I had a test done a couple weeks ago.
Did they have
I
you
was
wear
worried about it, but
Did they have you wear one of the recorders like for an extended period of time to see if you're having like cardiac episodes at night?
no, they just did the breathing test.
Do you have a cardiologist?
No.
Okay. I'll talk to you after. Because you might need to just have like a Zeo patch or something put on, which goes on the outside, but it can see if you're having cardiac events while you're sleeping, but you're in such a deep sleep that you don't wake up from it. Because there's certain times throughout the night that our body releases our natural hormones, and some of the evidence behind some cardiac arrest and why people have cardiac arrest early in the morning is because of those surge of natural hormones. I'm not a cardiac expert, but it's definitely something to look into. Okay. So we'll try to figure out, I'll talk to you after, we'll figure out who your primary care is, and maybe they can some of the primary cares can order it, or they may refer you to a cardiologist just to make sure there's nothing going on. Because especially if it's only happening while you're sleeping. Okay. Any other questions about the risk factors? All right. How many have heard of the acronym FAST? How many have heard of BFAST aside from looking at your book? Before you came here, how many knew about BFAST?
Because I got something from BB in the mail.
They're all changed to BFAST. Okay. So we try to use an acronym, and it used to be FAST. which is face, arm, speech time, and we will go through each of them, and I'm going to show you how to test your significant other or neighbor or whoever. Look in the smile or mirror and see yourself. But we realized we were missing some posterior strokes. So we went and we added in B, the B and the E, so B fast. Why do we do B fast? So let's talk about our neurons in our brain. Okay? Do you think we have thousands, millions, or billions? Billions. Okay? That's still not a very big number when I tell you how much we lose with every time we lose oxygen and blood flow to the brain. So with a stroke, we said ischemic strokes, right? It cuts off blood flow and oxygen to the brain. For every second, we lose 32,000 neurons. How much do you think that equates to aging our brain? 8 hours for every second. For every minute, it's 1.9 million. Bye. 3.1 weeks, we've now aged our brain. For every minute. For every hour, we're now at 120 million. That doesn't get us very far when we have billions. We're now in years. 3 years we aged a brain. Now, realistically, how long do you think it takes for us to get someone in the ER?
Into the ER, seen by someone in the ER.
No, into the ER. And I'm going to tell you why it's important for you to call 911.
By ambulance, my husband, they had him there in 15 minutes.
From the time that the stroke started, the symptoms started, that's what I'm talking about. From the time the symptoms start, how long do you think it takes someone to come to the ER?
Hours.
I just had someone wait 3 days, and now they are permanently disabled. What made them come to the ER is they woke up and they literally could not move the right side of their body. But they were complaining that their hand was fat for the last 2 days. They ignored the signs and symptoms. Okay? It's not always something simple. Look at the big picture. Yes.
Their hand was what?
Their hand felt fat. They lost some sensation in their hand. You know, like when it feels like it's asleep, it
Right.
feels like it's swollen. That's the feeling the patient had. And then they woke up on day 3 and couldn't move the whole right side of their body. The symptoms with ischemic stroke, the patient had TIA symptoms, which are the same symptoms, but they didn't get checked out. So we couldn't fix what was causing the problem. And that little clot just kept moving until it reached a vessel that it couldn't pass anymore, which caused the paralysis. Okay? It's really important to not ignore those signs and symptoms. So with BFAST, the first thing we do is check balance. How do you think we check balance? Please don't have someone stand on one foot, because it would probably be their weak foot. Okay? Just have them walk. There's a thing, it's called truncal ataxia. It literally looks like the upper half of the body is not connected to the lower half of the body. They look like they're intoxicated when they walk, completely uncoordinated. You can ask them if they feel intoxicated. You can say, do you feel intoxicated or do you feel like the room is spinning? Why do I want to ask them those 2 questions? Does anyone know the condition that mimics a stroke, that causes the room to spin? Vertigo. We get vertigos in all the time. I'm going to tell you about 30% of them are actual strokes. Vertigo, it's a symptom of Meniere's disease, which is a fluid imbalance in the ear. And then you also have benign positional vertigo. The difference with those 2 is they get worse when your position changes. You go like this and you're like, ooh, okay? With a stroke, it's there all the time, regardless of movement. So we ask them if they just feel off, or do you truly feel like the room is spinning? That helps us a little bit try to say, this may not just be vertigo. What do you think happens with the vision? Blurred? Double? Could be. What part? Peripheral. What is your peripheral vision? Yeah, it means I'm staring at you, but I can still see him. Have you ever been in the inner city and you see those horses with the blinders on? That's literally what it is. When we're testing stroke patients that have lost peripheral vision, they can't see anything. We physically have to move them so that they can see our hand. They lose that peripheral vision. Do you think it happens in one eye or both eyes? It could be both. So just be mindful of it, okay? Set your balance in your eyes. Those are your posterior stroke symptoms. They often cause headache and nausea. Headache because normally when you have vision issues, you get a headache. And when you're off balance, you sometimes get nauseous. Now let's move to fast. How do you think we check the face for a facial droop? If you're by yourself and you think something's off, look in the mirror and smile. If you see more teeth on one side than the other, please call 911. Nowadays, you can tell Siri to call 911. I'm serious. I was in a class once and I said, hey Siri, call, just example. And she's like, do you really want me to make this SOS call? No, I don't. But you can do that. Or if you have a life alert button, push it, okay? You can't really do it if you're by yourself because sometimes we have expressive aphasia and you're not fully understanding. The face one we can do. A stands for arms. If you are with someone and they seem off, please have them put both arms out at the same time, not just one, because you don't see this arm falling. Now you see this arm falling, okay? This is going to be your drift. It's really important to try to do both at one time. If one is drifting down and after you do this, have them squeeze both your fingers at the same time. If I thought she was having a stroke, I would say squeeze both my hands. The reason is because the weakness may not be that much different, but you will notice it if they squeeze at the same time. So please just have them squeeze both fingers at the same time. They might have numbness and tingling. Their hand might feel fat, okay? Their tongue might feel fat. It's because of the paralysis. It causes just issues with sensation issues, okay? What do we think happens with speech? That's our S. What else? So we have slurred speech, okay? Do what? There are 3 types of aphasia with stroke, and this is really important in the elderly, okay? Expressive aphasia means I understand what you're asking me to do, but I can't do it. Bobby, what is this? I know that this is my phone, but I will look at this and stare at it for a second, and I'll call it something else. What do you think is going to happen to me as a patient? Knowing that I know that that's my phone, but I just called it something else. No. Who said dementia? I'll get into that. That's receptive aphasia. They get upset because I know that that's my phone, but I just heard myself say something else. So they understand what you're asking them to do, but they can't do it. They get really, really frustrated and they get really, really scared. Receptive aphasia is what we have to watch out for our dementia population. They're confused anyway. Receptive aphasia, they can't even receive the information. They might have word salad. They might start, tell you a whole story, but it won't be in any context to what you're asking them to do. Because they see you talking to them, they hear your mouth move, or they see your mouth moving, but they can't receive any of the information. So they just mumble, mumble, mumble. Anything they want. You have to watch that and look for those other signs and symptoms if you think something's wrong. Because if you're looking at someone and thinking they're having a stroke, it's not just because of their speech. Sometimes it is, but most times there's something else going on. They might have a facial droop, okay? Then there's global aphasia. Global aphasia is both. What do you think these patients do? They can't receive the information and they can't express information.
They get very frustrated.
They're mute. A lot of times they're mute. They just stare off because they can't process or express information. So a good number of these patients can sometimes just be mute. Okay. And then we talk about time. We talked about the 1 second, 1 minute, 1 hour, right? Time is really important, and this is why I tell people to call 911, even though the hospital's right there. I don't care if you live right there. The reason is because our stroke protocols at the hospital start when EMS calls in and says, I have a stroke alert. EMS can get to you almost quicker than you can get to the hospital, park, and get in and get registered. We're still going to see you as fast, but there is a delay. Okay? We're still going to treat you quickly. But pre-notification by EMS, they have scores that they use. One is a Cincinnati pre-hospital score that says, okay, I think you're having a stroke or I don't think you're having a stroke. They're going to check a blood sugar. Maybe your blood sugar is low because that mimics a stroke. But then if they have positive scores, they do a modified VAN score, which is kind of what we do with BFAST, but to a different extent. If that is positive or negative, if that's positive, they're going to call in a stroke alert. Depending on the score, they may say you need to go to Christiana, not BB, because Christiana can go up and pull the clot out. So it's important to call 911 because they have their paramedics are beyond experienced in recognizing strokes. But they will start the process before you even get to the ER. They call in, if your VAN score is positive and we think we're going to have to ship you out to a higher level of care, we have a really nice big button on our wall in the ER that we push. There's times that we have a helicopter there before you even get there. It's all about the patient, and it's all about saving your brain and trying to make you who you are today, even after your stroke. We have patients that come in very, very sick. Because of the communication with EMS, they literally go up to Thomas Jefferson. We give them TPA because they're within that close window, and I'll go over that in a second. We then fly them up to Thomas Jefferson University Hospital in Philadelphia. They go up, pull the clot out, and the patient walks home. Not physically, but walks out of the hospital. I can't guarantee if you didn't call 911 and that process didn't start before you got to the hospital that it would be the same outcome. When EMS calls in a stroke alert, you go right to CAT scan. You don't even go to an ER room. We open the table before you even get to the hospital and make sure there's not a patient because your brain is our priority. We very much understand time is brain, okay? That's why I say, and please call 911. Just let them assess you. They don't charge you to assess you. Sussex County paramedics, the big white trucks that go around, they don't charge you anyway. They would rather them get 250 calls a month and see 70 people than see 70 people when they should have saw 115. I promise you they don't mind. I educate them all the time. They love it. They love their jobs. Okay? Don't be afraid to call them.
Are you talking about not being charged just for the stroke symptoms or for anything?
When Sussex County paramedics show up, Sussex County paramedics themselves do not charge you. The Sussex County paramedic is a government program. There is no fee to have a paramedic come to your house when you call 911. Now, the BLS crews, when you are in an ambulance and Lewes has to take you, I can't tell you that Lewes doesn't send a bill to transport you. But the paramedics that come and evaluate you do not charge you. You will not get a bill from Sussex County paramedics.
And they don't transport.
They can't transport because you won't fit in their truck. So they call BLS crews, and yeah, I think the BLS crews, because they're the firehouses, there's a small charge for transport, but there's no charge for them to come and evaluate you, okay? But would you rather pay that small fee or be debilitated for the rest of your life? So that's why I try to tell people as well, okay? The medication that I was talking about is this medication, and I gave each of you a brochure on it. Not everyone is a candidate for this medication. There is very, very strict inclusion and exclusion criteria. When you come to BB, after your CAT scan, you are greeted with a robot. On that robot is a Jefferson stroke provider, a critical care physician specially trained in stroke medicine. They evaluate you with the assistance of our providers and our nurses to evaluate you and say, yes, give this to them, or no, they're not a candidate. Either your last known well is too long, or your risk is greater than your benefit, because this is a very, very potent thrombolytic. It is meant to dissolve the clot. So we need to make sure we don't put you at greater risk for more complications before we give you this medication. But I like to give this out to you guys so that this is reinforcement. We cannot give this medication if your last known well is greater than 3 hours. What do I mean by last known well? According to who? According to the person that called 911, not you, the patient. The reason is because if you're experiencing expressive aphasia or receptive aphasia, you may not know when you were well. So we go based on the information to who the reporting person is that called 911. All right.
What if this person lives alone?
You call 911. They'll come check you out. That won't 100% exclude you. They're going to try to figure out who you last spoke to, see if they can talk to that person, and see if we can try to get a timeline. Because even if you're outside the window for this, if you come to the hospital and you have a large vessel occlusion, which means one of the main arteries in your brain is blocked off, they can do a mechanical thrombectomy, which means, who's had a cardiac catheterization? This is the same type of procedure, but they go all the way up to your brain. They just keep going up, okay? They go up and do a clot retrieval. You can get that up to 24 hours if it's a large vessel occlusion. So don't think, oh, I wasn't feeling well yesterday. Well, yesterday what time? Don't not come to the hospital because you think it's too late. All right? So we have a couple different time windows to work with, but the important part is the early recognition of those symptoms, not ignoring those symptoms, and calling 911 so that we can activate our protocols before you even get to the hospital. There is a program that we use called Triage. I did not misspell my words. It's a mixture between triage and Twitter. Okay? I don't know if that's really what it is, but it makes sense. It's a messaging app, HIPAA friendly, where Sussex County paramedics can send us a picture of your driver's license and your insurance card, and we can get you registered right as soon as you enter the doorway. Now, if you call Sussex County paramedics with chest pain and they do an EKG and it's showing a STEMI, which is a heart attack, they're going to pre-register you. You're going to go straight to the cath lab. So there's so many benefits to calling 911. Sussex County paramedics, Delaware paramedics as a whole, is one of the most advanced systems in the country. There's one thing that they have done. They just upgraded all their GPSs. So that if you call 911, you may not get the paramedic from Lewes because maybe he's all the way up in Angola. But if there's one at BB Hospital that came from Bethany Beach, he's coming here. They get the closest one to you. Their average response time for strokes from time of call, and I measure it. Dave knows and Mary Beth, I'm very, very strict about my statistics. Their average response time for a stroke is no more than 5 to 7 minutes from the time they get the call to the time they arrive. The paramedics. Their on-scene time, which means the time they pull up, not the time they get to you, the time they pull up to the time they leave to go to the hospital is less than 12 minutes. That means they're doing 2 different assessments. They're contacting medical control. They're contacting RER. They're initiating the stroke transport. They're doing an EKG, doing a blood sugar, getting you loaded in the van and off in 12 minutes. On average, it's about 8. Then you get to the hospital and you're within the CAT scan machine, on average within 3 to 4 minutes. There are so many benefits to calling 911. Please don't be afraid to call 911. You have some of the greatest paramedics in the country right here. So use them. They love what they do. Okay? This brochure, before I go into the different types of stroke, this brochure right here, this Be Fast, this is a refrigerator magnet. Mary Beth asked me to bring some freebies, so I brought you the ones with the refrigerator magnets. So you can stick it on your fridge. If there's 2 of you here, give it to a kid or a neighbor and have it stick it on their fridge. This right here, I write an article for stroke for Good Housekeeping in Women's Day magazine every year for Stroke Month. I also write an article for Cape Gazette. This is just last year's article. I just started preparing this year's article. Stroke Month is in May. So you'll see a lot of stuff come out on social media about Stroke Month. This book right here that she cheated on, I really like this picture. I am not responsible for this picture, which is why I put the credit at the bottom, but I love this picture. This tells you the difference between what your right brain and left brain control. So this really helps you to kind of understand what your brain is doing. It doesn't go into detail into the different lobes because that's a different level of education, but it gives you a general census. Every patient that comes into BB Healthcare, even if they're a rule-out stroke, if they get consulted by me, they're getting a little workbook. Everyone can benefit from the knowledge of knowing their risk factors for stroke. You go through, you circle, you highlight, you write your A1C, write your cholesterol. It's going to tell you how it affects your risk for stroke. In the very back, I have listed medications. Go through and circle and highlight if you're on any of the medications. You should know why you're taking medications. I have a lot of patients that come in and I'll be like, why are you on that beta blocker? I don't know, my doctor prescribed it. Please know why you're on your medications. I'm very finicky with our nurses and their education and making sure that when they give you medications specifically for stroke medications, so antiplatelets, anticoagulants, statins, that you know why you're taking your medications. Mary Beth's fancy program, she's our Cypher discharge nurse. It has a question in there, actually 3 questions. Do you know why you're taking your medications? Do you take your medications as prescribed? And do you have any questions about your medications? We have an automated program that calls you, Dave.
2 days after discharge from the ER for inpatient. 1 day after.
Yeah. So it calls you at increments and it has set questions. If you answer and hit a prompt a certain way, it will prompt her to call you. If it's a difficulty with a resource or a medication or a follow-up appointment, she then sends you to me. Or she sends, you to me, and then I call you to try to help you figure out what we need to figure out. Okay? It's a very strategic process that we have in place for our stroke patients and multiple programs throughout BB. But the medications are good. If you have had a stroke or know a family member that's had a stroke, we partner with Thomas Jefferson University Hospital in Philadelphia. BB has a tele-stroke and tele-neuro program. Thomas Jefferson is one of the highest ranked hospitals in the country for neurology. We have the robot. They're there at the drop of a hat. Okay? Yeah, they're hundreds of miles away, but they're here and they help us treat you. If you or someone you know has had a stroke and they're looking for a support group, we use their support group. They are the experts. They can just take a picture of this little QRS code or they can register below. They can submit questions ahead of time. You can submit them anonymously. I can get referrals back if sometimes if they put that they're a BB patient, I've had their neurologist reach back out to me. Dr. Sheehan was like, hey, Bobby, I got this patient. Can you please reach out to them and help them? They had a family member that was really struggling with aphasia, the expressive aphasia. So I went up to our ICU, I got one of our aphasia boards, and I drove it to her house. Now she can point at the pictures of the stuff that she needs. She doesn't need to try to say it. We go and we get flashcards, taking them back to apples and bananas and A's and B's and C's to work with aphasia. But it helps us when we know when you're having problems. Okay, so don't be afraid to ask. Any questions about this booklet? Okay.
I don't have a question, but I just have a comment.
Sure.
After the stroke I had, I got a ton of information. I couldn't read. I wasn't able to process.
You had the receptive aphasia? So what can happen in that case when you get the phone call with the prompts? Did you get the phone call with the prompts?
I said I never did anything with them.
Okay. Because when you get the phone calls, it will ask you if you want to speak to a nurse. And you can push the number to yes, and Mary Beth will call you and we'll figure out what we need and we can go over everything with you. But I'll get your phone number afterwards and I'll work with you. Okay?
Well, I can read now.
Oh, well that's good.
No, I'm 6-7 months
Yeah.
beyond and I can read again.
Yeah.
Yay.
But if you ever need help with anything, my number and my email are in there. Yeah, absolutely. Please don't hesitate to use them.
This would have been helpful too for my husband to understand.
I just started putting them in there about 6 months ago.
Okay, because
Yeah.
he didn't understand what my problems were.
And that's one of the reasons I made the workbooks, is to help the families as well. So that there is a role strain for people that have strokes, especially if the person who had a stroke is a primary caregiver of the family, because now the roles have switched at the drop of a hat. There is role strain. I have had conversations. There was one patient that I met with their family. I had family meetings with the husband and the daughter and the caregiver 3 days a week for 4 months. The patient had fired every medical provider because she didn't understand what was going on. She swore nothing was wrong with her. So I didn't want to get fired. So I worked with her family and her caregiver, and we created a plan. And we got her where she needed to be, and now she's able to talk and communicate again. So there's a ton of different avenues that we can work with. I'm a very empathetic person. I have a very personal connection to heart attack and stroke, okay? I want to make sure that you guys have all the tools that you possibly can need to be better than you were when you had your stroke, and as close as who you are today, okay? And even continue your recovery, okay? So just help us help you. I do want to go over some statistics from BB, and that is because I think it's important for you guys to know what's going on in your community. How many strokes do you think we have cared for so far this year at our little small hospital? Now I'm talking patients who come in and have a primary, so first major diagnosis under the stroke umbrella.
700.
We're at 620 as of October 1st.
See, the rest of them were in November.
We've had a lot. Yeah. We have already surpassed 2019, 2020, and we're almost passing 2021's data.
Wow.
A big part of it, though, is our TIAs are skyrocketing, and I could never be more happy. I don't mean it like that, but it means that people are not ignoring the symptoms. So I pull several statistics, okay? In the beginning of the year, so I really started honing in on community education in June of 2021. I noticed there was a huge trend and a drop-off in our TIAs. In January of this year, 57.8% of our patients were acute ischemic strokes. 15.6% were TIAs. As of October, 44.6% are TIAs and 33% are strokes. We have totally flipped the channel. Our stroke numbers are still climbing, but we are way less. So our lowest year is 2019. We had 232 acute ischemic strokes. In 2021, we had 330. We're only at 254 for 2022. It's going to mean a healthier, go ahead.
So if I am understanding your statistics right, Bobby, it means more people are coming in when they think something's happening, and you're seeing more TIAs, which are those little events that are like a precursor to a stroke. And you're seeing fewer strokes because more people are paying attention to those symptoms, calling 911 and getting in before it's a really big issue.
Yep. So, another big thing, okay? The number, I look at our medical history for everybody. Our annual average right now for hypertension and hyperlipidemia are our two highest risk factors. 59.6% of our patients have come in with hypertension, and 46.8% have come in with hyperlipidemia, high cholesterol.
That's for stroke or for TIA?
Stroke. Well, the whole stroke umbrella. Okay.
Is that untreated, Bobby? That you're saying those, or are they, were they on
They just
medication?
came in with a past medical history of it. Okay. So the big thing is those are two controllable factors. So if we can drop that, we're going to drop it even more. The other thing I look at is what symptoms they came in with. Our symptoms, where did that one go? Initial exam findings. In the beginning of the year, 53.8% came in with weakness. 38.5% came in with aphasia or the language issues, right? But our strokes were higher. Last month, 40% of our patients came in with absolutely no neurological symptoms. That's because they're TIAs that were resolved, but they still said, something's wrong, I need to go get checked out. When they showed up, they had no neurological symptoms. These statistics are really important to me because they tell me where I need to educate. And what I'm doing right now is apparently working, because the last 3 months we've had more patients with no neurological symptoms come in than every month prior.
There's just some buzz around here. Can you just explain what a TIA is?
That's what I'm getting to next. Yeah. So that's what I wanted to go into next. Okay? So real quick, talking about the gender. You know how I told you more men are at risk for having a stroke, but more women have strokes, right? I can tell you, based on our statistics, literally here in our primary service area, it is 50-50. Some months there's more women, some months there's more men, but our annual average right now for 2022, 49.9% male and 50.1% women. We're literally 50-50, okay? So I can't gear my education to that. So I gear my education towards comorbidities and recognition of signs and symptoms. I also trend how many people come in by EMS and by private vehicle. I know it's really hard for someone who has no neurological symptoms but thinks something is wrong to call 911. So as long as our no neurological symptoms are high, I'm okay with our private vehicle being a little high. I would be worried if it was 60% weakness and our private vehicle was still high, because that means you're actively having a stroke while you're driving your car. Okay. I monitor all of these statistics for our community, and I educate. Every education I'm giving updated statistics, because I think it's important that you guys know what's going on in your community.
And what is the age range on the recent incidents?
Mm-hmm. So annual average so far for 2022, 46 to 65 is 19.9%. 66 to 85 is 61%. And greater than 85 is 16%. And that is regardless of disposition. When I say disposition, that is our charts when we pull them, regardless of whether we keep you at BB or we transfer you out. So these are true statistics. They're not just statistics of the patients that we keep at BB. So this is your community. Yes?
You know, I suspect fact, there's a lot of people like myself who live alone, and I even wear a like alert, but that's just for a fall.
Mhm.
It doesn't seem too realistic. You're having a stroke and you try to find that phone. Well, I would just have to hit this. You try to find that phone and you try to, and then you have a page when you're trying to.
So if you push your life alert button and you can't respond to them, they are going to send a paramedic. If you can't talk.
Yeah, unless you got, well, you probably wouldn't have, you probably be able to use one hand, I guess.
I always try to tell people if you live alone, please at least find 1 or 2 neighbors that you guys can check in on each other at least once a day. Text message, phone call, hey, how you doing? 1 in the morning and 1 at night. Because we have several people that come in who live alone, who retire down here, and their son or daughter is not, they're busy living in another state, and they'll check on mom and dad a couple times a week. But their last known well's like 4 days ago because that's the last time their daughter or son talked to them. So talk to a neighbor or find a friend or somebody that can just check on you a couple times a day. And it can just be 2 friends, 1 in the morning, 1 at night. If you have more friends, that's great. I'm not saying have 2 friends. Have more than that. But try to make it a habit of checking in on each other. Okay? I can't tell you how many times we hear it was a welfare check because they couldn't answer their phone. They tried to call them 3 times, they couldn't answer their phone. So they called 911 and said, hey, I'm trying to find my friend. I know they're home, but they're not answering their phone. Can you please go check? And it's been a bleed or it's been a massive stroke. Okay, so just try to find someone or a couple people just to check in on you on a regular basis. It's really important, especially if you live alone. Okay, and just early recognition. So let's talk about the different types of stroke, because the only one that happens really quick is an intracranial hemorrhage. So let's talk about a TIA, a transient ischemic attack. When you hear the word transient, what do you think?
Impassing.
The symptoms come and go. These are all the ones that gets missed. Here's the kicker. We can't tell you if you've had a TIA till I can tell you you didn't have a stroke. Okay? You come in, you get checked out, we send you for a CAT scan first to make sure you don't have a bleed, even if you don't have neurological symptoms. If you report neurological symptoms, you're going to be getting a CAT scan of your head. In 24 hours, if you're eligible for an MRI, not everyone's eligible for an MRI because of the magnets. If you're eligible for an MRI, you'll go for an MRI. Because an acute ischemic stroke will not show up immediately on a CAT scan. The reason we do the CAT scan is to make sure you're not having a bleed so that we can then see if you're a candidate for this. Because if you have a bleed, you can't get alteplase. If you're not eligible for an MRI, you get a CAT scan 24 hours after the first one. Because if you had an ischemic stroke, it's going to show up on that second one. We check your vessels out. Do you have plaque? We do an echocardiogram. Do you have a patent foramen ovale that maybe you didn't know about? That's actually like a little porthole in your heart that can send those clots right to the brain without having to pass through the whole heart circulation. We check an EKG, see if you have AFib. You didn't know you had AFib. We check your cholesterol. I had an elderly woman, and when I say elderly, I mean upper 80s. Her cholesterol was almost 400. She had no idea. No idea. She ate out every night. But she was alone. She had a very high social life. That's fine. Her stroke was negative, but she had a positive risk factor. Her cholesterol was high. She's going to get diagnosed with a TIA. We can't see a TIA on a CAT scan because it's not a stroke. But if we check your risk factors and you have a positive risk factor mixed with the neurological symptoms, you're going to get diagnosed with a TIA. It's so we can treat you and we can manage your symptoms. If you're diabetic, you're going to go on insulin. You're going to get a little phone call or a visit from the diabetic nurse educator. She's going to talk about your diet, tell you everything you don't want to eat. She's going to talk to you about weight loss. She's going to talk to you about insulin. She's going to talk to you about trying to get that under control. If it's cholesterol, I already talked to you. We put you on a statin. If it's AFib, you're going to get a visit from cardiology so they can help you manage it. If it's hypertension, cardiology or medicine. But we don't know you had a TIA until you had a stroke, even if your symptoms went away. How can you have a stroke and your symptoms temporarily go away? Does anybody know? Nope. If you have really high blood pressure, there's this really good thing in our brain. It's called collateral circulation, which means there's other vessels that are helping to compensate, but your blood pressure is high enough to help perfuse them. But it may be a stroke, even if your symptoms go away. I promise you they're going to come back. It's just a matter of time, and when they come back, they may be really bad. TIA, the symptoms come and go. Acute ischemic stroke, the symptoms get progressively worse. So they started out as those TIA symptoms. My finger felt fat, my hand felt numb, I slept on it wrong, I worked in the garden all day, my shoulder feels weird. Now I wake up and I can't move my right side of my body. The symptoms get progressively worse. So if you start out with that numbness and tingling in the hands and it goes away and you want to be stubborn and don't go to the hospital, and the next time, now it's hard to lift your arm, please call 911 because that's really a progressive sign. It's a sign of a stroke. Okay? The acute ischemic strokes are your leading cause of permanent disability in the entire country. And it's because of the damage. Neuroplasticity is a thing. Our brains try to do a really good job of recovering from these type of insults, but they can't recover 100%. Brain cells don't regenerate. It just kind of learns how to function in its new role. Okay? That's not saying you'll never walk again if you were completely paralyzed, but it's going to take a lot to get there. And some people don't get there. I don't want you to not be able to get there. So I keep TIA and acute ischemic strokes in their own little bucket. I like buckets. You should see my office. So TIA and acute ischemic strokes, because they're ischemic events due to a lack of oxygen. Now we have a non-traumatic intracranial hemorrhage. What do you think I mean by non-traumatic? Yeah, nothing bumped your head. You didn't fall, hit your head. You didn't roll out of bed. Nothing hit your head. It's a spontaneous intracranial hemorrhage. Number one cause is uncontrolled hypertension. A non-traumatic intracranial hemorrhage is usually the day that people find out that they had an aneurysm that burst. Because we don't get routine screenings for brain aneurysms. The other thing is arterial venous malformations. They can be a cause of a spontaneous intracranial hemorrhage. An arterial venous malformation, once they go in and they embolize the bleeding, there's not as much risk of a recurrence as a ruptured aneurysm. Ruptured aneurysms have a high risk of recurrence. Okay? Why do you think intracranial hemorrhages, these patients decompensate very quickly? They get a massive migraine. We've heard it called a thunderclap headache. If someone's telling you they're having the worst headache of their life, be careful. Okay? It's literally called a thunderclap headache. Worst headache of their life. It's due when the aneurysm or AVM ruptures, when you start bleeding into your brain. How many holes do you have in your head? This is always a loaded question.
Too many.
One big one. Right here. It's called your foramen magnum. What goes up it? Spinal cord. What's right inside of it? What's at the base of your brain? It's called a brainstem. It controls all your involuntary functions. If I say involuntary functions, what do we involuntary do? Heart, breathe, and blood pressure. I have a bleed over here. I have no extra room in my brain for extra fluid, right? So it now starts to push my brain this way. Now I've come all the way this way. Where's my brain going to go?
Down.
Down. going to start to protrude out that hole. It's called a herniation. There is next to no chance of a meaningful recovery once you start herniating, and this can happen in minutes. The higher the blood pressure, the quicker it's going to happen. It is a neurosurgical emergency in most cases. 2 stories. In one weekend, we had several bleeds. I don't even know what happened in one weekend. We had several bleeds. But there was a woman that was out with her husband. She got a phone call. She went to the bathroom, took a phone call. It was a disturbing call. She came back out, started talking to her husband, started slurring her words. She hadn't been drinking. Then started profusely vomiting. They called 911 because at that point they knew something was wrong. She was intubated before she came to BB. If you don't know, that means she had an artificial airway put in because she could no longer maintain her own airway. We flew her up to Christiana Hospital. She died 2 days later. Her blood pressure when she showed up was 230 over 160. She had uncontrolled hypertension because she didn't take her medication, and then the stressful situation increased it even more. She had a ruptured aneurysm. Her aneurysm was back here, close to that brainstem. So the first thing it does is puts pressure on that brainstem. Okay. That same weekend, we had another patient who was actually 18 years older than that patient walk into our South Coastal campus. She had a history of migraines. This one just felt different. Yes, she drove herself there. Okay. This one felt different. It had nausea that wouldn't go away. We sent her for a CAT scan. She had a bigger bleed than this lady, but it was over here. And her blood pressure was the upper 130s over 80s, much more controlled. She's now at home with her kids, her grandkids actually. She went up, she had the hematoma removed, stayed up there for I think it was 10 or 12 days, recovered, and then she was discharged home.
So that outcome was better because the blood pressure was lower?
Blood pressure was lower in location of the bleed. It all plays a huge role because we don't have extra space in our brain to increase fluid. So our brain is a closed circuit, a very tight closed circuit. When you have a ruptured aneurysm, or if you have an insult to the brain that caused swelling, there's no room for our brain to swell. So what they do is when we send these patients to a tertiary facility is they actually go in, remove part of the scalp so that the brain can swell without causing the herniation on the brainstem. And sometimes it takes a couple months before they can put that flap back on because the brain will stay swollen, so they got to wait for it to come down. But it can literally mean the difference between who you are today, and I hate to be real, but 6 feet under. Control hypertension. It's the biggest. And learn coping mechanisms for stress.
Is there any thought to BB getting these interventional things like the clot removal that you're talking about? There's lots of older people moving here.
Yeah. As BB advances in care, I don't know where it will go, okay? I would hope in my little world that BB advances neurologically. We are, with our telestroke and teleneuro, we do have access to some of the best physicians in the country. If we give you this medicine, as of right now, we are shipping you. And it's because this medicine still has a risk for a bleed, okay? If you're really stable, our program is growing that in the near future we'll probably start keeping some of those patients, but your safety is our concern. I would rather ship you to a higher level of care where you just have to go down an elevator to an operating room than me have to arrange transport on a foggy night to get you to a higher level of care 2 hours up the road. So it's a fine balance, but your outcome is what means the most to me.
So, Bobby, are there hospitals that are certified stroke centers?
BB is a certified stroke center. There's 4 levels of certified stroke centers. There's an acute stroke ready hospital, which literally means they can give this medication, they can send you for a CAT scan, and then they ship you out. They have no inpatient beds. They cannot care for you there. They can't keep you there. Then you have a primary stroke center who is BB, Nanticoke, Bay Health, St. Francis, Wilmington Hospital, all the smaller hospital. Above that is Mechanical Thrombectomy Stroke Center. There are none in the state of Delaware. Above that is Comprehensive Stroke Center. That is Christiana. We have one in the entire state of Delaware.
And how is Christiana different than Jefferson?
They're both comprehensive centers, but we have a partnership. Jefferson is specialized in neurological, and that's just where our partnership is.
I just wanted to comment that one of the most important things is awareness.
Yeah.
And we, as in the nursing group here, have done once a month coffee hours with blood pressure, so that people who sometimes are surprised by how high their blood pressure is,
Yep.
Increase their awareness. As we begin the new year, we are planning to do that again, to start a blood pressure clinic during the coffee hours once a month. So we will have that available here at St. Peter's.
And you asked me about the Christiana, right? Our non-traumatic intracranial hemorrhages that require intervention, which is immediate, they do go to Christiana. Our acute ischemic strokes that require intervention go to Jefferson. Jefferson has several campuses that we can transfer our patients to. So if Center City is full, we can transfer to Abingdon. A lot of people are worried about the flight. Your insurance covers all but a very, very small portion of your flight. And it's because we can't provide those services here. We're sending you to a higher level of care. A lot of people are worried about that. We have partnerships with Jefferson's Patient Advocacy Department, so they have resources for hotels and restaurants at Jefferson. So if you have to go up there, your family has a more reasonable place to stay if they wanted to stay up there. And if you're at Jefferson for several days and still require medical management, we have an agreement with Jefferson that we will actually bring you back to the community and continue to care for you at BB. But it's that hyperacute phase. I don't really want to call it hyperacute, but the really critical phase where your brain is the most important thing to us, and we want to make sure you're at the absolute best place that you can be for it. Now, that's not saying we don't keep strokes at BB. We keep strokes at BB. But the very severe ones that are at risk for swelling again because our brains don't have room to swell, we will ship you to a higher level of care.
So I have a question. An aneurysm, I had a stroke that they called it a brain bleed.
Mm-hmm.
So is it the same thing?
So you either had an aneurysm ruptured or you had an arterial venous malformation. Those are the two causes. If they called it a hemorrhagic stroke, those are typically the two causes. So it's either a vasculature malformation or you had an aneurysm that you didn't know you had that ruptured. And some of them are small, but they can still. So there's some intracranial hemorrhages that are really small. If a patient's not on blood thinners, if their blood pressure is well controlled, that they will just watch and wait. But it's the what ifs. So we're really cautious with the patients that we keep because your safety is our concern. Any other questions? No? Any questions about stroke? Yes.
I have a question about rehab. If someone here recover from a stroke from Jefferson, they're here living alone, they need help.
Mm-hmm.
What facilities do you send these patients to for rehab?
So there's multiple options, and it depends on the level of rehab that they need. So there's acute inpatient rehab, which is like your PAM, which is post-medical acute. They're actually opening a new facility in Georgetown. There's a PAM in Dover. There's also Encompass rehabs. Those are the three big ones around here. Outside of that, we can send you to a skilled nursing facility if you need a different level of rehab. But there's also some patients we've had to send to long-term care. And then there's other patients that we're able to discharge home with outpatient PTOT SLP, which is physical therapy, occupational therapy, and speech-language pathology. So yeah, there's several. Our case managers work really close with the case managers at Jefferson. And if someone's at Jefferson and they need an inpatient rehab, they will do everything they can to get them down here. Yeah. I have a pretty good relationship. We also have the Bay Health Rehab, the inpatient rehab at Bay Health that they utilize as well, which is actually in the hospital. So, yes.
How much does the blood thinner reduce the chance of
That's a loaded question. That would probably be better answered for a neurologist. So there's two different classes of medications. There's an anticoagulant, which is a blood thinner, then there's an antiplatelet. The antiplatelet actually prevents the platelets from sticking together. That's like your aspirin and Plavix. Your Coumadin and your Eliquis are two of your higher level anticoagulants that we would use. It's all risk versus benefits. There are some strokes that we don't put on anticoagulants, but we'll put on aspirin. There are some strokes that come in that were on aspirin therapy or aspirin and Plavix therapy, which is double platelet, and they still had a stroke, so now they'll put them on an anticoagulant. So cardiology / neurology / a hospitalist, they all kind of work together to do your risks and benefits and figure out what is the most beneficial for you without increasing your risk of bleeding. So as far as like technicalities and statistics, I don't want to give you false information, but that's the difference between the two classes of meds and how we taper them. And there's some people that go on aspirin. It's mostly aspirin and Plavix combined. It's called dual antiplatelet therapy is what they'll put them on. And then if they fail that, sometimes they'll go straight to an anticoagulation. But there are some people who have AFib that need to go on anticoagulation because they have AFib for various reasons, or they have chronic AFibs at high levels, so they're at higher risk for clots. So they work really closely with neurology and cardiology just to figure out the best plan for you. Yep.
I have an older sister that lives alone up at Wilmington. Are there any smart devices that you know of yet that they can wear that would recognize symptoms?
Recognize symptoms?
Technology is always improving.
I don't think there's any that would recognize symptoms.
They will call 911.
Yeah, she could get, I think there's Amazon Alexa devices now that you can connect to your phone, and you can have them like there's little pods that she would be able to put like a pod in her living room, so if she fell and couldn't get up, she could say, hey Alexa, call 911, and it will. So it's, and Alexa can communicate back like, did you mean to, or do you want me to call, and they can communicate that way. But they're little flat devices. I think they're called the Echo Dots or something. They're really small, but, and they're relatively, they're cheap. She can put them in every room in her house and they'll all talk together. Yeah. I know. I have a 13 and a 15-year-old. I have them things all over my house. They scare the bejesus out of me sometimes. Because you can say make an announcement, and it will make an announcement on every single one you have, and they're like, ah! What's going on? Any other questions?
I have a question. If people are on blood thinners and they take a pretty significant hit to the head, should they come and just be evaluated?
Yeah, absolutely.
For the sake of that, would you repeat the question? Because I don't know.
Yeah, she asked if people are on blood thinners and they fall and hit their head, should they come in and be evaluated? Yes. And the reason is because some bleeds are slow. If they hit their head but not that hard, they still might have a bleed. I would rather them come in and get checked out and just get that scan, which tells us if you have a bleed or not. A bleed shows up on CAT scan. An ischemic stroke does not. So at least come in and get checked out and make sure you don't have a bleed, especially if you're on anticoagulation.
And the reason I said that is we have seen people riding bikes, even with their helmet on, and have fallen off their bike, but they think their head's okay because they had the helmet on Eliquis or
Yep.
and unfortunately things happen.
Yep. So when you fall and hit your head, your brain hits one side of the skull, then comes back and hits the other. It's at risk for bleeding. So even though you have a helmet, you're still at risk for bleeding. You may not fracture your skull, but that doesn't mean your brain, an area in your vessel in your brain is not going to bleed. So yes, if you are wearing a helmet and you fall and hit your head, please come in and get checked out. That's another loaded question. So it is no longer recommended for every single person. I know many years ago they said if you're over the age of 50 or something, you should take a baby aspirin every day. They've actually found it's a greater risk than it is a benefit. So I would check with your primary care or your cardiologist to determine your risk factor to see if you should be on one, because not everybody should be on one. Yeah. Any other questions? No? Thank you all so much for coming. Yes, Dave. Yeah. So real quick, I just want to introduce Dave Zumsky. He is from the BB Foundation. He comes to a lot of my programs, which is why he probably has the program memorized.
Not yet. Not yet.
Soon.
Ladies and gentlemen, can you feel the love?
Yes.
Can you feel the passion? We are so blessed to have Bobby Cole in our community doing what she does. Please, another round of applause for her.
Thank you.
You are truly one of BB's best and brightest and passionate about educating the community about stroke. And what she's doing is actually improving outcomes for everybody. So we are just so grateful for her. And we are also so grateful for all of you. Please share what you've learned today with your families, your friends, your neighbors. Encourage them to come to a future talk. Bobby's doing these a lot. I also need to call out to some friends, Wanda and Jim in the audience, and I know I probably have met many of you before, but I want to say thank you to all of you, because I know many of you support BB Healthcare. We are a nonprofit, community-based healthcare system. We're not affiliated with a big system. We're not owned by somebody in New York. We're yours. And it's your support that allows us to continue to grow, to meet the needs of the community, to do great things with our stroke program. So from the bottom of my heart, if you're supporting us now, thank you so much. If you're thinking about it, thank you for thinking about it. And if you have questions, I would love to answer them. Happy holidays.
Thank you all so much.